Shearing applied force extraction of lenticule by reverse pull with wow factor in refractive lenticule extraction. There is no financial interest in this video. Sometimes going in the reverse direction is beneficial. Femto laser makes 4 cuts. The first cut is a posterior lenticular cut, as you can see in profile view also. Then it makes the second cut, which is a side cut of the lenticule, which moves 360 degree vertically. Third cut is anterior lenticular cut, which goes beyond the posterior cut for better dissection. Fourth cut is incision taken at 110 degrees. As you can see in profile, the incision cut is seen. Laser makes tissue separation by series of air bubbles. This is the posterior cut. Energy is kept moderate, 150 nanojoules. First cut starts from periphery to center, and anterior cut starts from center to periphery. We are presenting a simple technique with better results. The need of less inflammation and early visual recovery. Strategic dissection is done for the optimal results. You create initial pockets anterior and posterior to the lenticule. This is the anterior initial pocket, and this is the posterior initial pocket. So further dissection is easier. We are going anterior to the lenticule now. While going posterior to the lenticule, we do a swiping motion so that posterior lenticule is separated well. Now we go obliquely away from the posterior pocket to the opposite side. Dissect left and right half. Then separate central 3 mm area behind the lenticule. Separate 180 degree away from the incision. Then paracentral quadrant is separated and only right paracentral quadrant is kept attached and removed last by using safe technology. This is very safe and predictable technique with minimal time required for the removal of the lenticule. The stoma around is not manipulated much. As you can see, we are going oblique away from the posterior pocket, go to the opposite end of the wound and dissect about 30 degree area to create a track from the incision to the opposite end. Then slowly we dissect above the lenticule in an anterior pocket. First we do the left half of the incision, then we do the right half of the incision. An anterior pocket is now completely separated. While going behind the lenticule, we depress the instrument so we enter into the right plane. Then we dissect central 3 to 4 mm area to create a potential space, and the separation doesn't become haphazard. Now we bake through the lenticule opposite to wound for about 180 degree. This brings the lenticule towards the incision. Then we separate the left para-incisional quadrant. So now only right paracentral quadrant remains attached. We keep it attached because that gives a control, and we remove the lenticule by safe technology. Check lenticule 360 degree, inspect for any tears. To get a wow factor, you should have less inflammation and early visual recovery. Do adequate hydration. Use lenticular pressurized dissection, that is whenever you are separating the tissue, press onto the lenticule for separation, so surrounding tissue is not disturbed. That gives early visual recovery. Do stomal massage vertically and horizontally. Milk out the BSS injected inside the wound. This apposes the tissue quite well. Operate under high magnification for better tissue separation. And as you can see at the end of the surgery, on table, on a slit lamp, cornea is seen crystal clear. This is the immediate post-op picture. And day 1, cornea is also seen more pristine, clear, with a vision of 20 by 20 in more than 95% of the patients. This technique is effective even in complicated cases like opaque air bubble. You can see left upper opaque air bubble. Do separation very gently. Remove left paracentral area by safe technology where air bubble was there. You can see black areas surrounding the central part showing inadequate energy or missing energy. While dissecting, take care that you are going along the plane of the lenticule to avoid tearing of the tissue. And once you do that, remove the tissue by safe technology. In conclusion, use safe technology, lenticular pressurized dissection, high magnification, adequate hydration and stomal massage. Now, relax, relax. Because it gives a wow factor and smile. Because it's safe. Shearing applied force extraction of lenticular by reverse pulling of lenticule. Thank you. Thanks a lot. Thank you.
Thanks, Dr. Jeevan. I next call upon Dr. Sameer Datar, a young dynamic corneal surgeon. He has a private practice and also he is a consultant at Dinanath Mangeshkar Hospital. Dr. Sameer Datar, please.
Thank you, sir, and all for the opportunity. I am more of a cornea person than a refractive, but then I'll just go through a few slides of whether trans PRK or PRK with MMC is a better option. So trans PRK is a relatively new modality where it is promoted as a no-touch refractive surgery. It is same as PRK but PTK plus PRK. So we'll just in brief see what are the features of PRK with MMC and features of trans PRK, and then pros and cons of both, and up to you to decide what to do. In the initial days of the excimer laser, PRK was with a lot of corneal haze and many problems and was not much in vogue, and then LASIK and SBK subomens came. But then this scenario changed with a smoother ablation profiles, larger optical zones, and then finally with the advent of mitomycin C, the haze was quite a bit controlled and outcomes of PRK were quite satisfying as comparable to LASIK. Though not many randomized studies were available in the literature for PRK and LASIK, there are few studies which are randomized where PRK has a statistically better UCVA, improved contrast sensitivity and less of higher order aberrations. Now higher order aberrations are more with LASIK in some studies that are present in the literature. Now with the advent of mitomycin C and its use on the surface to prevent haze, the scenario changed. So it's basically a DNA alkylating agent which inhibits the DNA RNA replication, and this is important for the fibroblast activity that is there on the corneal surface, which is required for wound healing, thereby suppressing the wound healing. So whatever advantages of suppression of wound healing you get, but along with it you get the disadvantages of suppression of wound healing as well. There is a lot of controversy, or there was a lot of controversy on the use of mitomycin C in these procedures, right from its use, its concentration, and the amount of time that mitomycin C will be on the surface. There are delayed wound healing was one of the major side effects or major complications. There are studies where the haze was significantly less, but few patients there was delayed wound healing, persistent epithelial defects, even with change in concentration from 0.02 to 0.002 as well. This is a patient of PRK with a haze. At the initial period of post-operative period of PRK, you do have this haze, but later on it subsides with time. With the use of mitomycin C, this time period is come down and patients are happy. This is a application of mitomycin C on the surface of the patient. Now there are various schools of thoughts which tell you what is the concentration to be used, what time the mitomycin C has to be used. Anywhere between 30 seconds of 0.002 to 0.02 can be used, and there are various studies comparing the use of 0.02 to 0.002. In this particular study, at the 12-month period, the incidence of haze was 7.7% in 0.02 and 5.4% in 0.002, though at 1 month and 3 months follow-up the percentage of haze was very high, but at the end of 1 month it came down to significantly and comparable to LASIK levels. The visual outcome was good. So the better, they suggested that it was comparable with 0.02 and 0.002, so it is better you use in a lower concentration to prevent the potential complications that you can have, because these patients, if you have any complications, it's a nightmare for you. 0.02 is more effective than 0.002. There are few studies which state this as well. But in this study, they also studied the subgroup, and in this study they had studied patients of high myopia of more than 6 diopters and higher ablation depths, and low myopia of less than 6 diopters and lower ablation depth. So for moderate myopia and shallow depth, low dosing appeared to be equally effective. Although in the subgroup, the duration of mitomycin C that was used, like it was from 30 seconds to 2 minutes that was used in the various patients, it did not make that much of a difference. So the duration of mitomycin, but general policy that is followed is 7 to 10 seconds per diopter. That is what it's used. There are very few studies which show endothelial damage after use of mitomycin C, but logically it is not explainable. Majority studies though prove its safety, and it is quite safe, not endothelial toxic at all. And there are randomized bilateral studies showing confocal microscopy studies for 5-year follow-up, where they have better outcomes comparable to that of LASIK. In trans PRK, what we do is, it is propagated as a no-touch technique where the patient lies on the table, and first you do PTK followed by PRK at the same setting. So you don't have to remove the epithelium with the use of alcohol swabs or by blades. This is PTK combined with PRK, and it's called as trans PRK. Now the epithelial thickness on the corneal surface is varying at various places, at various quadrants and points. So in the figure, if you see, the surface is irregular and the epithelial thickness can vary. So what trans PRK does is, with PTK, it will bring down the epithelial thickness to a particular level and make the surface a relatively smoother surface on which the PRK can be done. So that is the whole idea behind doing trans PRK. So instead of removing the epithelium with alcohol or blade, you do PTK and bring down the surface at a regularized level and then do PRK. So you don't have to touch the patient at all. That is a marketing point. But pros and cons of this trans PRK, we'll just see in the slides coming ahead. So this is how the procedure is done. This is borrowed from a public domain. Again, if you consider the data and the literature, UCVA, BCVA, you get refractive stability as comparable to that of Subberman's LASIK by 3 months. Initial period in 1 to 2 months, it doesn't seem that effective, but by 3 months and 6 months and 12 months, the outcomes are significantly comparable. Again, one hitch in this treatment is the residual refractive error, which is highly dependent on the epithelial thickness. Now, if you have diagnostic instruments to measure the epithelial thickness, you can feed the data into the machine. But otherwise, if you randomly put 55 microns, 50 microns or 60 microns, that much of epithelium will be taken care of by the laser, and then the PRK will be done in the residual stroma. But then if you look into the studies which are doing trans PRK, this epithelial thickness was highly dependent in predicting the outcome of trans PRK. So astigmatic correction, which was maybe less in patients with thick epithelium. If you have a thicker epithelium of more than 60 microns, then the residual error was more in cases of trans PRK. So there is a time where an algorithm needs to be set to, depending on the epithelial thickness, what amount of ablation you do for the surface, and to optimize better results. Recent comparative case series also, there was less pain and haze after trans PRK compared to alcohol assisted PRK. This is a large study of about 1,000 eyes, where preoperative spheres had a range of -7 to +3 diopters cylinders, and at 3 months 89% had target myopia of less than 0.5. And in short, this whole study shows that the outcome with trans-PRK was very good. But as I said, only the hitch in this is the epithelial
Can you please
thickness.
conclude?
Yeah. So pros and cons: if PRK with MMC, it's a time-tested method where intervention is needed and risk of MMP complications are there. But if it's trans-PRK, it can be promoted as a no-touch technique, which is epithelium dependent, and if proper algorithm can be catered to it, then it's useful. But then we have innovative ideas where you can do trans-PRK with and without MMC, and there are studies for that as well. So single-step transepithelial PRK with or without MMC showed similar efficacy in incidence of haze, total depths of ablation. So depending on the depth of ablation, the outcome of trans-PRK is achieved. So it's up to you to decide now. Thank you.
Thank you, Dr. Sameer, for a very nice talk. I'll just call upon Dr. Mukesh Paryani. He will be talking to us about microkeratome, pearls and pitfalls. He's HOD of refractive surgery in HV Desai Hospital and also has a private practice.
So, speaking about microkeratome in the presence of 6 prolific smile surgeons and femtos LASIK is certainly difficult for me. I will just try to defend my microkeratome on the practical pearls. Yes, thank you so much, sir. So I'll be just sharing the practical aspects of why microkeratome still holds key in refractive surgery. We are comparing something which is manual versus something which is a laser. Certainly, laser has its own benefits as well, but I'll be discussing some scenarios where I will rather go for microkeratome LASIK. So just see that amount of time that we are taking. Forget the left video is just not working. Amount of time that we are making a flap. These are the newer microkeratomes. The complications happening with the newer microkeratomes are fairly less as compared to the earlier microkeratomes. These are pretty fast, accurate, and yeah, femtosecond laser flaps, it makes flap pretty much predictably well in around 6 seconds or so. The flaps are wonderfully well. It has its own share of complications as well. Current microkeratomes, I have no financial interest in them, but certainly they are better as compared to earlier microkeratomes being gearless. They have a better suction. They have around 4 suction ports as compared to earlier microkeratome which had only 1 suction port. They have better angulations, less dependent on very deep socket and prominent malar prominence. So they come with a disposable heads. The flaps are relatively plainer. They have much better predictability, and they have a stricter nomogram. So the complications of a free flap or maybe buttonholes are fairly less in nowadays microkeratomes. There is certainly morphological difference between the flap edges made by the laser and by the femto flap, but I am not very sure what will be the optical implications. There are many studies which say the optical implications, recent studies, meta-analysis which say that the outcome is fairly same in both the LASIK surgeries, whether it's a femto flap or it's a microkeratome flap. Femtosecond advantages, the only advantages I would prefer for femto is the predictability. The predictability of having a flap of 100 microns in a way I want to is obviously certainly much better in a femtosecond flap as compared to a microkeratome flap. Specific femto complications are there. There are many papers which say and emphasize their specific femto complications which includes the transient light sensitive syndrome. Almost more than 95% of the patients they have transient light sensitive and opaque bubble layer if the energy is too high or the biomechanics are poor. The suction time is more, and DLK obviously is a little more as compared to in microkeratome LASIK. The other sides of coin, there are many studies which say there are no significant difference in efficacy, safety and complication rates between the femtosecond laser and the mechanical microkeratome. I again say the predictability is one factor that obviously makes femtosecond a little higher, but otherwise in all, if you see the complications of the femtosecond laser, close to or little less than 1%. Similarly, complications, any kind of flap related complication happening in a microkeratome is having of a similar percentage, approximately 1 or less than 1%. So yeah, as I said, the advantages of a femtosecond laser is mainly the predictability of the flap, the way you want to make it. The optical outcomes are fairly the same in both. Indian population, we have a huge set of myopia coming in along with the progression. This is an Indian study only, which says that we have a wave of myopia coming up in front of us now. So we have around 550 excimer laser machines and 180 to 210 femto laser flap making platforms in India. The average procedure, this is just by a survey, little survey verbally we spoke to different refractive surgeons in India. They said if they have a femtosecond LASIK and they have a microkeratome as well, still 65 to 75% are the microkeratome procedures. I'm not sure how the scenario has changed now, but this is what they have. So there is a lot of financial burden to the doctor. If you have a femtosecond laser, it's 10 times as compared to a microkeratome cost. The femto flap making platform is 10 times to a microkeratome cost. The patient interface in the femto is twice as cost to the microkeratome blade. Annual maintenance cost is certainly high. It requires a separate room, and burden to recovery, the cost is also there. The burden to the patient, in India, we are already facing the patients who are finding it difficult to pay for a regular microkeratome LASIK. Giving them an option of femtosecond LASIK only would also be very difficult for us. To a certain extent, it also builds an unrealistic expectations to the patients as well. So to conclude, if I am a patient, I would prefer a femto flap. If I am a surgeon, I would prefer a femto flap, but considering an Indian scenario, I would always keep a microkeratome with me as a viable option to be offered to the patient. Only if femto costs come down to an extent of a microkeratome, then it might replace microkeratome.
Thanks a lot, Mukesh, for giving us all the viable options at a lower cost. Microkeratome, the highlights of and the uses. Now we have another dynamic young surgeon, Dr. Vardhaman Kankaria, our in-house faculty, much sought after national and international faculty. He is going to speak on femto LASIK. Is it worth the cost? Vardhaman, please.
Microkeratome. If there is a small corneal opacity, femto flap is not going to be as smooth. So there, microkeratome is the only answer. So that was the indication for having a microkeratome. Yeah.
And we can just repeat it for the audience.
No, just for the audience.
For us, financial reasons are there, so microkeratome always works better. But if there is a small corneal opacity, femto laser is not going to penetrate. So there, microkeratome is the only answer. Thanks.
Thank you very much, and I would like to thank the Poona Ophthalmological Society for this opportunity. After an excellent talk by Mukesh, where he actually said that if he was a patient as well as a surgeon, he will prefer a femtosecond laser flap, and that holds true even for my talk. So I'm going to talk to you about if I want to make a flap, then I would like to make a flap with the femtosecond laser. I would rather not prefer to make a flap because my go-to procedure is Relax Smile. But I'm going to just discuss about the femto LASIK as a preferred option for myself. We all know that it was in 1990s when Professor Palikares performed world's first LASIK procedure, and this is the historic video because this is the first LASIK done in the world. So you can see that this is a mechanical microkeratome which is actually creating the flap. This was designed completely in-house. So this was a microkeratome which is manual. You don't have automated microkeratomes in those times. And now you can see the microkeratome is being lifted up. You will see there is a flap which is having a huge hinge. It's a very small flap. But of course, those were the early days. But this was beginning of a great revolution in refractive surgery because LASIK showed many advantages over the previous technologies. When it comes to the flap making technology, today we have two flap makers. One of them is mechanical microkeratome, as we know, and the second one is femtosecond lasers. The mechanical microkeratome is an excellent device, creates a good flap in great number of cases, but it has its own disadvantages, especially if you have a very flat cornea or if you have a very steep cornea. You can land up with free flaps and you can land up with what is called as buttonholes, and this can really ruin the outcomes of your patients. So as Thomas Edison says, there is a better way to do it and we have to find it. Emergence of femtosecond laser technology in corneal refractive surgery has really opened a new era in refractive procedures per se. Femtosecond lasers work on the principle of photodisruption, pretty much similar to our Nd:YAG laser, but the collateral damage is about 1000 times less as compared to the Nd:YAG lasers. So it tells us about the safety profile of these new lasers. So when you have ultra short infrared laser pulses, these are precisely focused inside the corneal tissue, you can see at its focal point, the tissue is disrupted and the small bubble is created. By placing these bubbles next to each other, you can create a pattern of any shape and size into the corneal stroma, and that's why not only as a flap maker, you can use these femtosecond lasers also to create smile lenticules. So this is a small animation which shows how the femtosecond laser is being applied. This is what is called as a docking. When you do the docking, you are upblending the cornea, and once that is done, you have the laser pulses which are being fired, as you can see on the right side. So once the flap creation is done, basically you lift the flap. Once you lift the flap, you will see, as against the mechanical microkeratome, the undersurface is dry. So you are actually doing the laser ablation on the dry surface, as against the wet one which you have to dry up with the help of sponge. So this is the flap which we are trying to lift. Once the flap is lifted, the excimer laser ablation is done. We have to just put the flap back in its place, and the procedure is over. So there are many advantages of this femtosecond laser flap as against the mechanical microkeratome, and the first and foremost, as we have already seen, is a very accurate and reproducible flaps. So if I want a 100 micron flap, there is a great chance I will land up between 95 to 105 microns. This is very crucial if you are actually dealing with thinner corneas. As Indians, we know that Indians are born with thinner corneas as compared to the Western population, so this is extremely important. The second thing is that these flaps are completely independent of keratometry. So if I have a very flat cornea, or if I have a very steep cornea, you can create a good flap in every single case as against the mechanical microkeratomes. You can also customize the flap. That means that if I want a flap thickness which should vary, or if I want a flap diameter which should be large, you can create that. And that is especially important if you want to create a hyperopic ablation, because the hyperopic ablation goes into the mid-periphery. It is not only that, you create a better shape of the flap. As you have seen, the femtosecond laser flaps are planar as against the mechanical microkeratomes, which are thinner in the center, they become thicker in the periphery. The edge of the flap, as we have seen before, is better with the femtosecond lasers, but there is definite advantage of that. Because the fit is better, you reduce the chances of epithelial ingrowth, flap slippage, microstriae, as well as dry eye. This is a small study that we had done. So basically, this is electron microscopic comparison between the two femtosecond laser flaps as against the Schwind microkeratome, which we had done in the University of Crete some time back, and it is published in British Journal of Ophthalmology. What we have seen is that the flap smoothness was much better when it was a femtosecond laser flap as against the mechanical microkeratomes. And of course, this has taken psychological fear of blade away from the patients. Of course, it is bigger, it is more expensive, but it is definitely my preferred preference in general, and especially in these cases, such as where the possibility of complications are higher with steep K or a flat K, if the predictability of flap thickness is important, such as in thin corneas, where I want low suction, such as glaucoma suspect cases, where I want to customize the flap, if I'm planning a wavefront guided or topography guided treatment, such as Contura, and as we have seen before, the mechanical microkeratome flaps will be preferred if you already have a corneal scar or a previous corneal incisional surgery. Thank you. Thank you very much. Thanks.
Thank you, Dr. Vardhaman. Now I invite Dr. Madhuri Chandorkar. She is a senior refractive surgeon in Pune. She is going to talk on SMILE. Is it for all?
Colleagues on the dais and friends, and I would like to thank Dr. Vardhaman for going through the entire gamut of what a femtosecond laser can do, because we always look at these things from the doctor's point of view, the technical point of view. My subject is SMILE, is it for all? So we always consider it from the medical point of view, the technical point of view. So I thought I would look at it from the patient's point of view, and I am just presenting the practical aspect of it. As I said, we have already seen the benefits of the femto laser. So we are aware that there are many types of refractive surgeries, and having done PRK exclusively for something like 22 years and then shifting to LASIK, I have always been a little uncomfortable with the concept of a flap, though we are doing a lot of femtolasic now. And as we know, the femtosecond laser is a common one between the lenticule creation in SMILE and as a flap maker in LASIK. So what are we looking from a laser refractive procedure, or in fact, what does the patient want? The patients are looking for safety. They always ask, is it 100% safe? They are concerned about the quick recovery, and they want to know, is the result permanent? Is it painless? What is the incidence of dry eye? And is it likely to be stable? Because a lot of them have already gone through the net and they have heard about undercorrections. We are actually dealing with an instant result generation. They don't have time for anything. They don't have time to look after. They don't have time to recover. So we find that Relax Smile is able to fulfill all the patient's requirements. So it's a very, very versatile procedure, and it has very few limitations in that at the present moment, commercially hyperopia treatment is not available. It is very, very accurate and precise. And one of the plus points is that if you have a borderline pachymetry, say between 490, 500, 510, and you have a low myopia patient, you could proceed with the SMILE without any problems, and it's very, very atraumatic. As we know, it is a non-surface, non-flap treatment, and the fact that it is bladeless and painless makes it very, very acceptable to the patient, because they are quite scared. Though the results have been comparable in many cases, the fact that we don't use a blade makes it very acceptable to the patient, and there's very little aftercare. So we are all aware that the femtolaser beam is normally in contact with the intact corneal stroma for only 10 raised to minus 15th of a second, which means that once the laser is applied, there is no acoustic trauma to the surrounding tissues or any because of the radiation of the acoustic waves, and therefore no physical damage. And the tissue dissection is by bubble formation, so the cut, actually intrastromal cut, is also very small. And therein we have the accuracy, precision and efficacy, because we can create any kind of profile that we need to make for the spherical correction, the cylindrical correction. And coming to the range of treatment, in PRK there was a great deal of limitation in the amount of treatments which could be done. And same for LASIK, you have a slightly thinner cornea, you're not too sure of what happens to the cap thickness, your range of treatment is limited. So here you can do spherical corrections up to minus 10 diopters, which will soon fall in the range of minus 12. Cylindrical corrections can go up to minus 5, and even pure cylinders do very well. And in moderate to high myopias, of course, they work very well because there are no undercorrections. Whatever it is that you're keying in, the nomograms are so designed that you would get the complete correction. So, and at a very conservative estimate, you underpromise the patient and tell him you'll see 90% next day, whereas at least 90% of the patients would see at least 6/6 partial. And it's a misconception that SMILE cannot be done for low myopes. What actually happens is that somebody who comes to your OPD for a -1 may not ask for SMILE. Probably the cost is a little prohibitive, and he's pretty okay without glasses. But there have been a lot of patients done for -0.75 also. And there was a patient who wanted to join some airlines. So we have done it even for 0.5. And with a little bit of practice, it is very easy to do a 0.5 dissection also. So not only do we have excellent results in high myopia, we have excellent results in high astigmatism and pure cylinders, because pure cylinders tend to be grossly undercorrected many a time. So this is the refractive suite. And as we know, why is SMILE so important? Because we have the concept of the lenticule extraction is something which is way different from what we were doing up till now. And it is minimally invasive, and not touching the anterior cornea is a big boon, because it allows a very quick recovery and there is no change in your shape. You use a large diameter zone, and you'll find that your higher order abrasions are also not introduced, and the patient will have a good night vision. So it is biomechanically stable even in whenever you have borderline pachymetries. So because it's a small incision, typically 2 or 2.5 millimeters, you would have 80% less side cut, 30% less cap cut. We preserve the upper corneal layers, we maintain the biomechanical stability. There has been a lot of talk about this and there are a lot of papers. As I said, I'm not going into the academics of this. And much fewer nerves are severed.
Madhuri,
There is no
30
cap,
seconds more.
so no flap. Yeah, I'll just. So we have a lenticule, we have an intact anterior cornea and Bowman's membrane. No flap cut, no displacement, no flap complications. Less dry eye because we are not cutting nerves. Minimally invasive because we are not touching the surface. 97% of predictability between plus and minus 0.5. A curved contact cup, so you always get a planar cut. And an apparently simple procedure which has a fairly steep learning curve. You need a good head positioning. You need correct docking. That makes all the difference between your separation. Then lenticule separation, it's very important to keep to the plane and don't create a false plane. Patient cooperation, of course, and a huge amount of chair time, because that is when you're going to get a good result. You're not going to have suction loss. You're not going to stop the procedure in between. And I'll skip this video because we have already seen how SMILE is done. And it's probably the best 30 seconds of your life. The take-home message is that if you have a procedure which will not cut open the eye, which will cover all entire refractive range and give you a quick recovery, give you a good biomechanical stability, I think SMILE is the way to be. Thank you very much.
Thank you, Dr. Chandorkar, for an excellent presentation. Next, I would like to call Dr. Natasha Pahuja. She is currently the Cornea and Refractive Service Head at Natasha Eye Care, Pune. She's also a clinical and research scientist at Grow Labs in Narayan Nethralaya. She has 100 plus international and national presentations with 30 plus peer-reviewed publications. Her areas of interest include keratoconus, refractive surgery, dry eye, and she's won the Colonel Rangacharya Award, which is the most prominent in her list of awards. So over to you, Natasha, to talk about ectasia predictors.
Thank you very much for the kind introduction. While we are all rampant about doing refractive surgery, my talk is just about statutory warnings. So what are the predictors and how can we go about this? So these are very simple known factors. We have post-LASIK ectasia, so to say, which appears by about 2 to 5 years of time, but these are the known factors. Let's take one by one. So one is the natural course of the disease. Now this is an individual. She presented to us when she was 20. Over a period of time, we just wanted her to turn 21 and then we can take her of refractive surgery. But her mom was a little finicky, so we didn't take her of refractive surgery. So if you look at it, over a period of time, she went and developed frank keratoconus, whereas the initial topography shows fine. Now, if we would have operated this girl, we would have probably ended up blaming refractive surgery and not the natural course of keratoconus. So it's very important to, so how do we actually see it? If a patient is coming to us, we are obviously going to take up the patient for refractive surgery. How do we see is, when you're slightly suspicious of the topography, now this case for instance, this young lady developed post-LASIK ectasia as is clinically seen. We did not have a preoperative topography, but what we did have is her 30-year-old sister. So we asked the sister to undergo topography. So if you look at the sister's topography here, there is slight posterior elevation in both her corneas. We also imaged the father. The father also showed suspicious corneas in both the eyes. Similar was the case with the mother. So the mother also showed posterior elevation in both the corneas. Now this we have seen up to in 30 families where we are seeing that patients developed keratoconus, not post-LASIK ectasia, but their families also show some suspicion. So if you are not sure if it's a topography slightly suspicious, it would be important that you image the entire family if they are accompanying them. So the take-home point from this is that it's important to image the entire family. The next is we always have these ectasia risk scoring systems. The most widely accepted is the Randleman ectasia scoring system. Along with that, it is important that we also calculate the PTA. So it's just not one factor, it has to be multiple. So how do we actually calculate the PTA? Is a simple example. Now in this case, for instance, the ectasia risk scoring system was 2. But if you look at the PTA, She had a 110 flap thickness, obviously. Ablation was 138. The thinnest corneal thickness is 504. The PTA was 49.3, which is not normal. So this case is actually not right for refractive surgery, whereas the ectasia risk scoring system says she's fine. To move on further, shifting gears from the topography to corneal biomechanics, there is enough published data, it's beaten to death that corneal biomechanics is an important factor, but how do we incorporate this into the clinic? Let me show you this case example. Now this is an ophthalmologist friend of mine. She has a very small refractive error, wants to undergo refractive surgery. If you look at her topography, there's superior inferior asymmetry. Now if you look at the Bellin-Ambrosia enhanced display, the total D is 1.56. The standard deviation is 1.60, very close to the suspicious topography. What would you do in such a case? Would you go ahead with the refractive surgery or not? How many of us would go ahead with refractive surgery in this case? A very small refractive error. No? Sorry? Observe for some time. That's one way to, absolutely, that's a very practical point. You will observe for some time. But if she's quite adamant, what we did was we actually imaged her on the corpus, which is giving us the corneal biomechanics. So the structural analysis from the topography and the functional or the innate property of the cornea from corneal biomechanics is what gives us. So what does corneal biomechanics, the TBI, the total biomechanics index, this is a combination of both the devices. What it essentially does is it gives us the corneal biomechanics properties, which we are very intuitively known to, the corneal topography, and the total index. So the bad D on the right side, if it is in the red zone, definitely not a good candidate. Now the corneal biomechanics index, if it is closer to 1, not a good candidate. And the total biomechanics index is basically artificial intelligence and mathematical modeling, which tells us if it is the patient, along with the total combination, is it fit for surgery or not. So let's look at this case example. If you look at the bad D is in the green zone. It is a regular astigmatism. Now if you combine the whole thing, if you actually look at the corneal biomechanics properties, it's coming very close to 1. So if it is it's coming close to 1, that means the cornea, although topographically looks normal, it is a weak cornea. So it is not a good candidate for refractive surgery. On the contrary, if you look at the slight skewing here in this topography, the topography is slightly suspicious, but if you look at the corneal biomechanics index, the cornea is actually quite strong. The total biomechanics index, although slightly suspicious, this patient can actually be taken up for a surface ablation or advanced surface ablation. Now again, a missed FFKC, this we don't need to ponder over it. If you have slight elevation and you just miss it, then probably you will land up with ectasia. The important factor is when you have a normal topography and you want to probe further as to why are these cases developing ectasia. This is what we have found, that the nature of the eye and the response to eye to inflammation is changing. Now this in our study, we had 6 cases who had post-LASIK ectasia. They had normal pre-op topography. What was interesting was that all of them had confocal microscopy and all of them showed increased dendritic cells. Now dendritic cells are a sign of inflammatory process. They are not supposed to be present in the center of the cornea. So we went ahead and probed further and we looked at the inflammatory markers in the tears in these individuals. If you see, they were compared to controls. Now the controls had normal inflammatory profile as compared to the post-LASIK ectasia patients, which had 2-fold increase in all the inflammatory profiles. This is after the LASIK had been done. So basically, and which is important to note here, they did not have any signs of dry eye disease. What are we essentially trying to say by this is that these individuals, what is important was they had increased OSDI to begin with. Now OSDI is freely available questionnaire. We can just distribute this to our patients before the surgery and see if they have higher OSDI. It would be important to treat the subclinical inflammation before we take these patients up for our elective procedures. Again, which explains why there was increased dendritic cells and a tear inflammatory profile supports the hypothesis. Now this was published in Bhide, in British Journal of Ophthalmology 2 years back, and this has been the first paper which has for the first time described why post-LASIK ectasia can happen in normal topographies as well. So a preventive strategy, very simple on this. If you have increased inflammation, it would be important to treat the inflammation before we take up the patient for surgery. How do we treat? Simple, start with a simple OSDI questionnaire or a speed questionnaire. These simple questionnaires help us titrate our patients better, treat them subjectively as well as objectively, and most importantly, if you feel that they have subclinical inflammation, for instance, testing for MMP9 with inflamed dry eye. If you feel they have subclinical inflammation, it is important to put them on anti-inflammatory. Even soft steroids work wonders sometimes, and then put them on cyclosporin and take up these patients after 3 months after checking their inflammatory profile. So a clinical implication, it is important to prime our patients. Like we would not take up any patient who has high blood sugar level for surgeries. It is important that we take up these patients, prime them before the surgery, and then go ahead with the surgery for better outcomes. Thank you very much.
Thank you, Dr. Natasha, for a very nice presentation. I now invite Dr. Jayant Sarvate to give his talk on Contoura making a difference. Dr. Sarvate is a senior refractive surgeon, a pioneer from southern Maharashtra, and he trained in Germany for his refractive surgery, wavefront LASIK. He has been doing cataract, IOL, glaucoma, squint. He started an eye bank in Satara, and he also established the first ever laser clinic in 1996. And he has many national and international papers to his credit. He's a life member of IMA AIOS and member of ESCRS and ACRS.
Thank you.
Dr. Sarvate also performs ICL phakic implants. The list is endless. Please go ahead.
Thank you. Thank you for this introduction. I'm really thankful for the Poona Ophthalmological Society for inviting me here. All flapless, advantage, disadvantages of flaps. I am going to talk on how to improve the visual quality in case of a refractive surgery. So this is what we are going to say, that Contoura vision, that is a new paradigm in refractive surgery, how we can qualitatively improve our results. It's because why it is different, it is conceptually different, and it is our march towards quality over quantity. We have been doing wavefront optimized treatments. These are aspheric treatments, doing the peripheral ablations more. Then the wavefront guided treatments. These are the aberration guided treatments, and the topographic guided treatments. These were especially used for the secondary treatments where something went wrong in the primary one. But now we are talking of a primary topo-guided laser vision correction in cases of myopia. It uses a corneal topography of each cornea rather than the wavefront to reshape it, performed on Wavelight IQ and EX500 models using a Wavelight topolyzer and a special treatment planning software. And it's done on this, the aberration profile is on the surface of the cornea is measured individually. The treatment is not centered on the pupillary axis or the optical axis. It is centered on the apex of the cornea or the visual axis. That is the most important difference. And the topo-guided ablations allow a unique shape of each cornea to dictate the placement of extraperipheral pulses. I cannot go into details because I have only 6 minutes to give you, so technical details I have already omitted, but I will give you the results. The wavefront, why it is different from the routine treatments which we are doing, the wavefront optimized treatments or the aspheric treatments, they use a population average of the peripheral blending, and the wavefront treatments are centered on the entrance pupil. Whereas the Contoura vision takes into consideration the asphericity value of individual cornea, that is the Q value of patient's own cornea is determined, and the asphericity of desirable endpoint of the asphericity of each cornea is measured with the help of a special instrument, and that is imprinted onto the cornea by a software guided program. The prolate shape of the cornea minimizes spherical aberrations and provides better quality of vision, and the alignment between the periphery and the center of the cornea is very important, otherwise patients experience halos. And here the corneal tear film is most important factor, whereas we have to address the dry eye pattern first before doing any refractive surgery. And of course the posterior cornea and the crystalline lens also impart aberrations, but they are already taken into consideration. So balancing the refractive surface is important. I'll just go through the a video which will give you a detail of what we are doing with Contoura Vision. It's a software guided program where about 22,000 points on the patient's cornea are already mapped, and this is linked to the laser platform. Laser detects the predictability of all these points. A topographic map for each cornea is created, and this corneal map, which has been accepted by the machine, and this gives you individual map which can be treated with the help of examer laser. What does it do? This is a Allegro topolizer which creates this map, and this creates a thumbprint like impression onto your cornea, and this gives you a individualistic high quality vision, HD vision, as you can see. This map is imprinted onto the cornea with the help of a laser, and it smoothens out the higher order aberrations onto the cornea to give you a perfectly prolate aspheric shape. So this is the US FDA results, which I am just giving you an idea. The more than 98% were extremely satisfied. It overperformed glasses and contacts, and as compared to the baseline, it improved the common symptoms associated with LASIK. And this is what we have been doing. We have been doing this for last 3 years now. 620 eyes done, the minimum follow-up of 4 months and maximum follow-up of 24 months, which has been studied in this study, and subjective improvements in the patient's complaints of night vision, halos and glare,
Sir, 1 minute
starbursts.
more.
Yeah, it's almost finished. So significant decrease in the higher order aberrations. So this is the case scenario which we have been talking about. As you can see, there are many higher order aberrations pre-operatively. The post-operatively, only the defocus is there, other aberrations are gone. Second eye, this also shows the same pattern, higher order coma and other aberrations, they are totally getting vanished. Third case again, and as I can tell you, all these cases, there were not high cylindrical value cases. This case is a case with -2 sphere. She has these many aberrations onto the cornea which have been reduced totally, and she is extremely happy. And I have done a night marathon runner who wanted to have his glasses removed. So this is how the improvement of the visual quality in terms of night vision and glare, that gives you a Contoura vision, which is a vision with a difference. So this is the analysis of our cases. Significant decrease in higher order aberrations in about 93% of the cases, and only 7% they had post-op readings which showed no deterioration in aberrometry, as was told that the LASIK gives you higher order aberrations are more with LASIK. So this performs definitely better in terms of decreasing the aberrations. So to conclude, a contrast sensitivity and night vision problems were definitely decreased, and our results also were comparable to US FDA study. Thank you.
Thank you, Dr. Sarvate. I request Dr. Madhuri Chandorkar to present a moment to Dr. Sarvate, 2 senior refractive surgeons. Thank you very much.
So we know that Wavelight has a precision, that is, it is designed to create ablation profiles which minimizes spherical aberration, maintains corneal's natural asphericity and preserves image quality with the help of enhanced repetition rate of 500 Hz, advanced eye tracking technology, non-contact online pachymetry is there, and high definition optics along with integrated Wavelight's late illumination system is also there. So what is new? So Wavelight Streamlight is new. So what is it? It is a one-step trans-epithelial PRK. First epithelium is removed with excimer laser energy, which is a non-refractive PTK mode, and then stroma is reshaped into excimer laser energy, which is wavefront optimized. This enhances usability and increases the treatment speed compared to alcohol procedure, PRK procedure, which is a 2-step procedure, and it enhances patient comfort, which is compared to alcohol PRK. So it is an intelligently designed for increased efficiency for surgeons, because the delivery system PTK plus PRK is there, which is a streamlined procedure, and it has a multi-dimensional eye tracker which remains active throughout the both procedures, automatically aligns the size and location of the PTK treatment zone along with the PRK ablation zone. So it requires only one centration throughout the procedure. Also for patients, it is a very good experience because there is no manual corneal epithelial removal, no touch or laser only. You just have to put the speculum, center the cornea, ask the patient to look into the light and start the treatment. Just press it and the treatment is done. So it is basically, because it is alcohol free, it is faster, requires only few seconds, quicker, and definitely because there is no alcohol, the inflammation is less and the healing is much more faster. So definitely it is better than PRK because as we see, epithelium is removed gently with the laser, less trauma to the eye, and even the healing cycle is very low, approximately 3 days. So it is a valuable alternative to LASIK, that is PRK LASIK, and same decision making process as PRK, and which are the candidates for traditional LASIK when there is thin cornea, dry eyes, questionable corneal stability cases. Patient preference also, if the patient is very anxious, they are afraid of the microkeratome, or if the patient is in contact sports where injury can cause flap, injury to the flap. So all these candidates are good for these. How is it performed? As we have said that first we do PTK, that is a non-refractive removal of surface epithelium, and through the same program we can reshape the corneal stroma to a refractive effect. So only one centration is there which enhances precision. Optic zone sizes can be automatically determined by the laser based on PRK ablation profile, and multi-dimensional eye tracking is there. So these are the zones, parameters which we are used. So myopia we can correct almost up to -10. Myopic astigmatism, spherical 10 and cylinder 6, but combined you can correct up to 10. Hyperopia again till +3, hyperopic astigmatism, spherical max 3 and cylindrical max 3, and if it is a mixed astigmatism you can correct spherical max up to -4 and cylindrical up to +6. So these are the optical zones which are required for wavefront, whatever is required. So for epithelium aberration it is +0.5 more than the what you require for the LASIK, that is for the central zone. So this is the zones which are required. Epithelial depth you can measure it on OCT, which would be appropriate, but there are nomograms available where you can based upon your own surgeon's technique you can correct these nomograms. So it can go from 45 microns up to 65 microns, depend upon nomogram or the correction based on OCT. So software features again from PTK to PRK is indicated by a yellow arrow there. So there is an arrow where you know, and there is change in sound also. You have a heads up display also, so you don't have to look at the monitor at what stage you are. So in your heads up display also you can visualize where the things are and where it changes from PTK mode to PRK mode. So there is sound alert option is also there, and treatment details are on the monitor. So this is a graphic user interface. This is because of the user enhanced usability, and high contrast is there, which is good in dim illuminated atmosphere. So this is same all monitor also. It is this is main area, header is there, menu bar is there, taskbar is there. So better you can see the things better on this.
Dr. Mehta, you have 40 seconds now.
Yeah. And there is color discrimination is also there. So blue for ready. So immediately you have come to know that you are operating right eye or left eye. Lime is for left eye. And here is the heads up display. So you can see whatever is going on when you are looking at the eye of the patient. So this is a streamlight from Wavelight, which is a one-step transepithelial PRK and a redesigned user interface, and again a harmonized look for the Alcon surgical suite. Thank you.
Thanks, Medha. Excellent review on the subject. Now I call upon the young and the dynamic guest faculty, Dr. Shail Vasavda, son of Dr. Abhay Vasavda, We have already introduced him, but a short CV for those who have just entered. He did his post-graduation ophthalmology in Ahmedabad. Then he did his fellowship on cataract and phaco in the Raghuti Pai Hospital. Then he did his general ophthalmology in LVPI, 6 months fellowship at the Modern Eye Institute, Salt Lake City, Utah. He has got more than 10 peer-reviewed journals. He has won the Video Ultrasound Biomicroscopic Innovator Award and also been awarded determining the elastic modules of Descemet membrane stain with trypan blue using atomic force microscopy. And then did a lot of challenging cases here. I present to you Dr. Shailva Savda, sir.
Introduction, and thanks again to the Poona Ophthalmological Society. I think all of us are, and before I start the talk, our hospital does receive research grant support from time to time from Alcon Laboratories. So I think all of us are in a quest to achieve as close to natural vision as much as possible in all possible of our patients. And I think although we do understand limitations of current science and technology, if given an option to every individual who's never had to use glasses before 40 years of age would always prefer if he could continue doing that for the rest of his life. And there are various current options that are already available since quite a long time. The traditional multifocal IOLs ranging from plus 2.75 diopter ad to plus 4 diopter ads. The low ad multifocal IOLs, or the so-called extended depth of focus IOLs, having ads ranging from plus 1.75 to plus 2.5. The Oculentis Symphony and Restore 2.5 being the glorious examples. And trifocals IOLs are also not in that sense new. Trifocals IOLs, I think Physiol has been the pioneer for trifocal IOLs, and the Zeiss, AT Lisa and Physiol have been there for a while now. And recently Alcon has of course come up with the Panoptix IOL. So the traditional multifocal IOLs have been popular and have been giving us good results in select category of patients because they give us good foci for distance as well as for near. But in the last decade or so, with the evolution of laptops, iPads, mobiles, I think if there's one thing that has changed world over, no matter the age of the patient, it's the use of intermediate distance activities, and that could just not be computers, it could also be iPads for people staying at home, or large screen mobile phones. And to address these issues, that's why all of the companies started coming up with IOLs with less power ads, so that although the reading for the fine print reading patient would require some glasses, but their near foci would be a little further off, that is close to the intermediate or close to 50-60 centimeters, which would be a normal working distance. And intermediate distance, we realize it's not just what they show in brochures or what we see in US or Europe websites. It's not just computers alone. If you look at our own scenario, this was the first time when I realized what intermediate distance is, when one of our patients told us that he is very happy with a +3 restore, but whenever he does puja, he is unable to see the actual head of the murti. So he finds it quite embarrassing quite often that he ends up going a little bit here and there. So intermediate distance is important in puja. Intermediate is important for business people when they do not only their now it's no longer the books that they sort of do puja with. And this is the distance that we are talking about, close to about 60 to 65 centimeters, just more than about an arm's length. When you are playing cards, you want to see not just your cards but what's lying on the table. And even if you are running the country, you need this range of vision which is close to you as well as little bit further away from you. So you need good near as well as intermediate distance. Now the traditional trifocal IOLs follow the basic principles of optics. So if you decide to have a near point of say 40 centimeters, which in good faith is an excellent near vision, optically the second focal point can only be twice the focal length that you have decided. So if you have a 40 centimeter near point, your intermediate will be at 80, then your next focal point will be 120, and so on and so forth. And that is why the current generation available trifocal IOLs of say Physiol and Zeiss have an intermediate distance as at 80 centimeters with a near point at 40 centimeters. But like we realized in all of these photos and all of these examples that we show, 80 centimeters in real life is quite far off. So what we essentially require is something right from our mobile to somewhere right now where my desktop or this laptop is. So we essentially need some range of vision from 40 to say 60, 70 centimeters, which is going to be the more functional intermediate vision that most of us are going to require in our day-to-day activities. And to do that, it's not possible with the so-called traditional trifocal technology. So what PanOptix is, by optical principles, it's actually a quadrifocal IOL. So what it has done is it's sort of created a fourth foci, and it's actually, when they make the steps, whatever way they do it, they've actually chopped off that third foci. So instead of, they've created 40, 80, 120, and they've chopped off half of that step to create an intermediate distance at 60 centimeters. So you have three foci point. One is infinity, that is far. The second is an intermediate point around 60 to 65 centimeters, and the near at around 40 centimeters. And at 3 mm pupil size, it gives probably right now the highest possible amount of light transmission, close to 88%. Although this difference is not hugely significant, even the competing Physiol and Ateles are somewhere between 86 to 87% of light transmission to the retina. So the actual design is pretty much similar if anyone has used a +3 or a Technis or similar brand multifocal IOLs. The difference in terms of the actual manufacturing is that the central zone has been increased. So it was about 3.6 in the +3 restore. It's increased to a central 4.5 millimeter diffractive zone. It's non-apodized, and the reason why apodization was there in the +3 restore is because it wanted to have a more better distance and near foci. The more you apodize, the better you get a distance vision, and here the focus of this IOL is mainly based on the improved intermediate vision. And there are more rings, 15 rings compared to 9 in the traditional multifocal IOLs, and therefore you will see more rings when you look at the patient on slit lamp. Surgically, it's in no way different. The injection techniques, the actual placement, the unfolding, and everything is as soft and as smooth as the robust Acrisoft platform, and extremely slow unfolding, so gives you a lot of time to maneuver. Even if things are not going as per plan, you have a lot of time to room to maneuver the place in the bag. And for any, no matter whether it's trifocal or multifocal or toric, you of course want a good surgery with a good symmetrical rhexis cover to make sure there's an effective lens position. We've had limited experience with PanOptix, not very huge, and this is we've done few more eyes now, but we don't have enough follow-up for all of them. So these are this is a case series of about 9 eyes, aged between 40 to 70 years, with a minimum follow-up of 6 weeks post-operatively. And what we analyzed is the unaided far, intermediate, and near vision. And all of these patients fortunately ended up with very less residual ametropia post-op, less than or equal to half a diopter, and fortunately the outcomes have been quite good. That is, binocularly most of them or all of them have 6/9 or better for distance. They have N8 to N10 at 60 centimeters and close to N6 to N8 at their reading speed, which is about 40 centimeters. Of course, for any kind of diffractive design, you must of course tell these patients that for the reading activities they are likely to require more light. So if they use more light, they are likely to read N6 more easily, compared to if there's a dim light, they are more likely to read N8 more easily. So in terms of range of vision, I think the main highlight or the major difference that PanOptix I think differs from the traditional trifocals is an increased range from near to intermediate functional vision. So even the defocus curves that have been published in literature have shown that all of the 3 competing trifocals are performing almost the same at 40 centimeters and at infinity, but it is in this in-between range from near to intermediate that probably, as of now, it appears that PanOptix has a little bit of advantage. So you get a good range of vision, right from infinity up to 60 to 80 centimeters. So the strengths of this lens are probably its more light distribution, better range of continuous vision rather than having separate foci for distance, near, intermediate, and therefore more chances of greater spectacle independence compared to the traditional multifocal IOLs. But of course, we must remember, and this is no magic, it's still the same diffractive IOL science. So there will be issues with glare, there will be issues with mesopic conditions, lower contrast sensitivity, and there are likely to be halos. So the patients that you select for PanOptics or for any, in that matter, trifocal IOLs, are you get an extra range of patients, but basically it's the personalities where you would obviously want to put a multifocal IOL, having understood the limitations of current technology. So I think,
can you just sum up?
Yeah, so this is the last slide. So I think picking the right patients still holds the key, no matter however good the science may have improved. But I think this is definitely one step forward in choosing ability to choose more patients in whom we can give them spectacle independence. Thank you so much.
Thanks, Dr. Shail, for the new toy in our armamentarium now. Now I invite Dr. Milind Pandey. He is known to everyone. He is a passionate teacher. He heads the vision surgery and research center in East Yorkshire, and he has a lot of innovative work, and he is a greatly loved ophthalmologist all over the country, and also gets in patients from Asia, Africa, and Europe and Caribbean. Dr. Milind Pandey. Can I invite all the speakers to come on the front line? Dr. Jeevan Ladi, Dr. Natasha, Dr. Sarote, Ridhima and Dr. Madhuri are here with me. Dr. Shail, Dr. Mukesh Paryani, Dr. Samir Datar, Dr. Vardhaman.
Have a suspicious cornea, irregular surface, a thin cornea, borderline tachymetry, or any problem, don't go ahead with the refractive surgery. I think that's the message that we should all carry. Only in the ideal conditions you should proceed.
There's always the option of phakic IOLs in those patients.
Yes, I'm talking about the surface ablation, sir.
What time? 1:30. Okay, so we've got 25 minutes. So, great. So let's race through this. So I've showed you this morning where I live and work, and this is what presbyopia is all about. It's
submitted for your approval. 4 people going out for an average dinner on an average night in an average city. Little do they know that a combination of dim light, small font, and aging eyes will conspire against them. For they are about to be taken to a frightful place, a dimension where even the simplest of tasks will prove impossible and cause utter humiliation. A dimension where the truth is right in front of your face, but you can't read it. A dimension where the closer you get, the less you see. They are about to enter the presbyopia zone. Meet Kathy. Beautiful, attractive. She's already had LASIK surgery. Running behind schedule, she decides to touch up her makeup at the table, yet it's not as simple as it seems. She still turns heads, but tonight, not necessarily for the right reasons.
You look beautiful, sweetie.
Let me introduce Robert, who previously had cataract surgery. He once was a naval pilot who had eyes like a hawk. Too stubborn to bring his reading glasses with him tonight, he's now flying blind.
Kathy, honey, could I borrow your glasses, please? Thank you, sweetie.
What?
So that's what our patients are worried about. It's about functioning without glasses for intermediate, near, for most of the range that we talk about. So what we're going to briefly go through is possibly look at some patients and some doctor factors which allow us to get better success with presbyopia lenses. So the first question comes, what do you tell the patients? You see a patient who's looking for presbyopia lenses, whatever. What do you tell the patient? Say I'm a patient, Jeevan, and you.
Yeah.
Bit leading. Would you like to get rid of your reading glasses for lifetime? Your distance vision will be either way you do monofocal, multifocal will be maintained well. If their answer is yes, then only we go ahead with our protocol for counseling for the multifocals or presbyopic IOLs. If they say no, we want to wear glasses after surgery, then we don't force them. Our discussion stops there and we do monofocal.
So if I act as a difficult patient, Jeevan, which I'm very good at, I'll say to you, you told me you get rid of my reading glasses for my lifetime. When I'm lying in bed reading in dim light, will I be able to read without glasses?
Yes, with the kind of protocol we have, answer is yes.
Can you guarantee that?
Not guarantee, but yes, they can.
Okay, we'll come to that. I'll show you why that's such a difficult thing to do.
I know what you mean, I know.
So it's very important, as we all heard, to modulate patient expectations. You have to tell them, at least that's what I find, we have to specify to our patients exactly the kind of vision to expect after surgery. Once you do that, then it's okay. But if you don't specify that, if you don't have a very honest and brutally frank discussion, then you stow trouble for further down the line. So in my practice, this is what I say to them. I said, without glasses and with both eyes open, you will 95% of patients see well enough to legally drive a car and to read a newspaper or read most things in good light. You will need glasses to read in dim lights, or if the print is too small or too faint, and some patients need glasses or prefer to drive in the dark. Less than 5% of patients need an enhancement to get that result, and less than 1% end up with worse vision than before due to any serious complications. So this is said to them brutally. It's written in a letter which goes to them. It also gets given as information booklets to them so that they know. And I find it's a great way of getting rid of those patients who just do not, engineers, surgeons, who want specific things. When I'm looking at my spreadsheet and this, can I read that? So I say to them, assume you won't. And that's a great way of rooting out patients who tend to do that. I always talk to them about contrast. We tell them the quality of your vision is not going to be the same as with a monofocal, but in exchange for that, you will see better for close. So the compromise is this, 2 deals. Monofocal, very good quality of vision, but you need glasses for intermediate and near, or a multifocal, with a tiny amount of contrast loss, which possibly your brain can make up, and you will see halos. And that's the exact word I use. You will see halos. You cannot get multifocal lenses without a halo. That's the law of physics. You have to go back to Newton and change his physics in order to get the halo go away. Everyone sees halos. They neuroadapt to them. You get used to them. So I say to patients, if you see a halo, I'm happy because the lens is doing what it's supposed to do. When the patient sees a halo after surgery, they feel good about it because they feel the lens is doing what it's supposed to do. And that's a great psychological trick. If you say, wo ho jayega thodi der mein, you'll get used. No. You will see a halo. You see a halo, it's a great thing because we know the lens is doing what it's supposed to do. And 99% of the times, patients get used to it, and it's a matter of time. And we talk to them about neuroadaptation.
But in Chicago, psychologist Hubert Dolezal has devised a bizarre way to test how well our brains can adjust when everything we've spent years learning is turned on its head. He's built a set of goggles that flip the world upside down.
Hello,
So,
Hubert. I'll
Hubert
cut short
has
the
been
video
wearing his
here.
goggles.
But basically, it took this correspondent 8 hours to learn how to ride a bike with those upside down goggles. So if your brain can adapt to that degree of visual challenges within 8 hours, what's a few halos? And everyone sees halos. They're always aberrations. There is no optical system on the planet which doesn't have some compromise somewhere. So it's about explaining this to the patient up front. कहते हैं ना, जब शादी होने से पहले सब माफ हो जाता है, एक बार शादी हो जाती है तो खत्म हो जाती है. It's a bit like that. Before surgery, everything's fine. After surgery, if they don't get what you're expecting, that's when the trouble starts. So deliver more than the promise. And this is really where you need to set the expectations. 20 happy. You heard this phrase. What do we mean by 20 happy? 20 happy is when what you said to the patient gets or does better than that. That's really 20 happy. Rather than 2020 or anything. Is that... Tasha, any comments? What do you think? Do you approach this differently? Any other comments?
I like that. This is very nice.
Yeah. It's very well put here.
So, which patients won't you touch? The obvious ones, patients with unrealistic expectations. मेरे को सब कुछ देखना है, बाहर का भी, अंदर का भी, इधर का भी, उधर का भी, halos भी नहीं चाहिए. You don't want to touch those patients. Personality types, people like Jeevan and me, intense, hypercritical, obsessive, occupational light drivers, medical exclusions, we all know that. Dry eye and amblyopia is really a key thing in terms of that. So let's get the panel's views on this. This is a 58-year-old who's had prior hyperopic LASIK, has a left esotropia of 5 degrees, minimal left amblyopia, best corrected 6/9, dysfunctional tear syndrome slightly, using readers and distance spectacles, cannot use contact lens monovision. That's the refraction at the bottom there. That's the aberrometry and the topography as such. What would you do?
The amblyopic eye, I would prefer to put multifocal lens with +4 add.
Okay.
And the right eye, obviously same diffractive lens, but add I can think about it.
So you're happy to use multifocal lenses in patients who are amblyopic?
Yeah, absolutely. We are using for anything which is better than 6/24. After explaining, we do it. 660 also we are done, but we tell them before that this is the issue, and we do it. No issue.
Because with amblyopia, the reading vision is affected more than the distance vision.
Correct.
And hence the neuroprocessing and the neuroadaptation is something which is unpredictable.
That's why I said +4 add, because it works like a low visual aids, and because the correction is at the nodal point, so they get something better.
They
And in addition to that,
bigger halo.
And in addition to that, we tell them also that with this lens, additionally, you may need a low visual aids at some time.
So if this patient, you do the multifocals, the patient then says, I get double vision because of the esotropia.
Why would she get diplopia? If the diplopia is corrected, then it might happen. But otherwise, is patient having diplopia?
6 degrees of esotropia.
Yeah, but she is not complaining of diplopia.
I didn't tell you that.
She would not at this stage. I don't think she would complain of diplopia now when she presented. She would not complain of diplopia after surgery also.
Okay, good. And 6/12 unaided distance vision. Anyone else take us for multifocals on this? Monofocal torics. Okay. So if you do a monofocal toric, her uncorrected distance visual will increase from 612 to 69. Worth doing surgery for one line?
I think what is missing is
what's the level of cataracts, that's what.
This is lens exchange, not cataracts.
Oh, it's in lens exchange.
Yeah, I would first see the potential acuity. If the potential acuity is good,
there's no lens opacity at all. The best corrected is 6.7.5 and 6.9.
Then I'm going to ask question. Then I ask question that in spite of multifocal, it may happen that you may not be able to read J1. You may have to go J2 partial.
Sure.
Are you going to be happy? If he's going to be happy, then I will consider multifocal. Otherwise, I will go for monofocal.
Okay. Anyway, I send this patient away. But I agree, that's a possibility you can do.
Absolutely.
There's no doubt about it.
Absolutely.
So we have all these different wonderful lenses, and how do you choose which one to use? It's what's panoptics, this, that, whatever.
Yeah, if the patient's potential acuity is better than 6/9 partial, and patient is actively working. Actively working means not necessarily driving, but he's doing some kind of work, then by default we put extended depth of focus lenses, explaining them about mini micro vision, vagara, and we do it. A patient says that he doesn't drive, he's indoors all the time, and he does all his work indoors. Then I put +4 add with a clear lens, no financial interest, but not yellow lens. So this is what we do.
Okay.
If there are people where the contrast is not a big issue, then I do mix match, but that is very rare. Now more than 90% of my patients, I prefer extended depth of focus, primarily not because of extended depth of focus, primarily because of achromaticness of the lens. That, it will give good contrast.
So it gives better contrast. So this kind of subjective assessments in terms of talking to patients and hoping they remember what they do through their whole life. But 8-9 years ago, I got fed up of getting caught out. So I worked this system out where what patients really want answers to is not 6-9, this, that. They want, can I watch TV? Can I play golf? Can I do this? Can I do that? We don't have any information on the basis of which we can answer those. So we developed a system where we call the panfocal visual acuity, where we do distance, intermediate, near in photopic conditions, Snellens, and near in mesopic conditions at set distances and set illumination levels. And along with that, patient in the clinic works on a desktop and a laptop to look at the same page along with the intermediate visual acuity, and they get given 4 reading tasks to do: a newspaper, a book, a shiny magazine, and a telephone directory. So this happens with every patient of mine before surgery, after the first eye, and after both eyes get done. And it's a great way of assessing lens performances. And just an example, this is a monofocal, panfocal visual acuity lens. And what we found was that if someone got 6/9 or better at all 4, they were spectacle independent for everything. So the target we really want to get our patients to is 6/9 or better from infinity to 40 centimeters, seamless, continuous in every level of illumination. The question is, can we do that? So you could take a monofocal and describe it at its 95th percentile performance, not the mean. Because when I talk to patients, I want to be sure at a 95% probability what performance of that lens is. So you could describe this single focus lens as a 6, 18, 30, 60 lens, because it gives you 6.6 for distance, 6.18 for intermediate, 6.30 and 6.60 for near in photopic and mesopic conditions at the 95th percentile. And this is the symphony, but more importantly, if you look at, I now have a database of about 2,000 presbyopia lenses, and we've looked at all the lenses as to which lenses give at the 95th percentile 6.9 or better. All the lenses do that for distance. The only lens that does it for the intermediate vision is the symphony. Near photopic vision, the only lens that does that is the ZLB, which is the Technis 3.25. And for near mesopic, there is no lens which gives you 6.9 or better at the 95th percentile. There's no lens on the market which does that. So once you look at these, then you realize that yes, their near vision for mesopic conditions cannot be that good on a predictable basis. It's not far off. You get 612, which is the best, but that's for the ZMB +4 techniques, which is what works. The other thing I tend to customize always is the customized ad. There's a whole range of these multifocals now, and each of these multifocal, the lens plane ad translates to a different spectacle plane ad depending on the antechamber depth and the cornea. So I calculate for every eye what the ideal intraocular lens plane ad is to generate a spectacle plane ad of 2.5 diopters. It's very easy to do. When you do your biometry, you choose emmetropia, 0 target, and then you choose -2.5 target in the spectacle plane. And the difference in the intraocular lens power between those two will give you the intraocular lens ad, which gets you nearest to that. So this is an example of a high myopic eye, and you can see at the bottom there, you need 3.9 diopters to generate 2.5. Normally it's 3.5 diopters. So this is where we need to get to. And the fact is, there is no lens which will do everything in every condition everywhere. So what are the options we have? We can customize lenses. So you can combine different strategies. And these are the various strategies you could do. You could have bilateral multifocals. You could have a monofocal or a multifocal. We heard about hybrid monovision. Or you could have an extended depth of field focus and a multifocal. So what we're doing here is we are modulating the monocular range of focus to generate a better binocular range of focus. The contrast and range of focus is the trade-off because you're adding multifocality into this. The other option is you modulate monocular defocus, which is the monovision, or if you use a symphony, you don't really have to put in too much because you can still have half a diopter at most or -0.75 diopters in one eye to get to that same level. So these are the panfocal visual acuity of the symphony nanovision, which is what I call it because it's less than -0.75. And if you look at the top left corner here, this is 157 eyes, 6.9 or better percentage. For distance, 100%, intermediate 100%, near photopic 96%, and 74% hit near mesopic. And they miss, that 70% goes up to 96 if you take it to 612 rather than 6.9. So just by using that functional assessment, we can tailor-make each and every choice. So if someone wants something, we choose a different lens and slot it into the other eye. This is their task performance. So this is the actual tasks they do in the clinic. And we see all intermediate near photopic tasks, they all perform that easily. The only task, bulk of the failure is they can't read a telephone book in dim lights. 1/3 of the patients can't do that. 2/3 of the patients still can. They also get given a questionnaire. So this is the patient's perception of what their vision is at distance vision in good light, distance vision in dim light, intermediate, and so on and so forth. And again, the two areas they talk about, distance vision in dim light, which is the halos. Again, doesn't stop them from doing it. It's just they see it and they wish it was not there. And near vision in dim light, which again, 1 in 4 patients feel it could be better. So, how much time we got? 4 minutes. One case?
Yeah. Please go ahead.
So this is a 67-year-old.
Sorry, before you go ahead, what's your target when you are doing symphony? One eye you do micro?
So we start with first eye, aim for emmetropia, see what the vision they get with the panfocal system. If they get everything they want, we just do the same for the other eye. We only induce the myopia if they want to read better, or we could put a trifocal or a panoptics or whichever takes your fancy. Sometimes if we put a symphony in one eye, the first eye, patient says, my vision is great, I don't like those halos, I can't get used to them, we put a monofocal in the other eye, because the binocular fusion will reduce the effect of the halos. So these kind of strategies you can only do once you have that kind of testing and you know exactly where the gaps in the vision are and what the experience of having the first eye done is. So we do the second eye 2 weeks after the first one. So they live with that vision for 2 weeks to see what it's like.
How much of myopia do you target for the second eye?
Half a
the
diopter.
symphony, yeah.
Half a diopter.
Half a diopter.
If you look at the fusion research, what it shows is that if the binocular anisometropia is less than 1 diopter, you get binocular fusion. But if you increase that, you get intraocular suppression. So the binocular fusion, the contrast, is less than single eye contrast, till you get to about minus 2.5 diopters, when it's much easier to suppress the other eye. So if you keep it under 1 diopter, it's not an issue. It's just normal levels of vision.
Sir, how do you simulate those light conditions of 100 lux and 400 lux in your clinic?
We have standardized lights that we put on.
For that, so you just put a lux meter into that, and you can just calculate it.
So we measure it, and once we measure it and validated it, just stick to that protocol. So it takes about half an hour for my optometrist to do this, but it saves so much hassle, and patients are much more confident. I'm much more confident in terms of what we do with this. Okay, just last case before we go for lunch. Small lady, about barely 5 foot, wearing gas permeable contact lenses, reads quite a lot, very high hyperope, as you see, +9, +8.5, also has significant amounts of corneal astigmatism. If you measure with all three, similar on both sides. Aberrometry again, this is something I do routinely, and I find the OPD scan great doing that, because the internal aberrations that you get with it are tremendous. And the op scan. I use the 3 millimeter central magnitude to work out the amount of astigmatism I need to correct as such. So this is, and when we measure out, this is using the Holiday system that we have, as 31 diopters. So the question is really, how do we approach this? What are we going to do for hyperopia, astigmatism, and presbyopia? That's kind of the framework to think about in all patients. So how will we solve the hyperopia problem? It's easy. You just take your 31 diopters or whatever that we did. For the astigmatism, just short of 1.5, 2 diopters. Toric lens as such. And for the presbyopia,
Presby is difficult, because if you look at the angle kappa that you put, is an 8 and 7.
Exactly.
So that's what probably is a contraindication for that.
That's one option. That's one reason why you'll have to be cautious about your toric IOLs. So what would you do if you want to do a toric IOL?
Yeah, I mean, probably in a hyperopia with an toric IOL. And also, I mean, if I want to do an toric IOL, I'll look at the angle kappa and probably look at an angle, and then...
So would you do a toric IOL in this lady?
I mean, it's very, very difficult situation, because...
So would you do a toric IOL?
I will do that.
I think, yes, probably, because 1.5, 1.75 diopter, even if you reduce it and you get some comma aberration into that, but it still is going to be a little better than what the pre-existing cylinder is.
Putting toric
Here the biggest thing is you are going to get a lot of comma aberrations after surgery. That's probably is going
alignment
to be
is more important issue in this patient. So toric symphony would be my first choice for this patient.
Okay. So I said to her, we will do a bioptics procedure. The toricity was an issue as far as I was concerned. I wasn't sure whether the toric IOL would sit exactly centered as it should. So I said, okay, we'll do LRIs, get rid of as much as we can, and whatever is left, we'll zap it with the excimer laser. Safe. You could work out whatever you wanted. So we did the non-dominant left eye. I put a fine vision trifocal and did some LRIs with it. And 2 weeks post-op, she was pretty good, 6.75 and 5. That was the refraction. So we got lucky there. The panfocal visual acuity for the left eye was 6.6, 6-6 for intermediate, 6-9 for near, and 6-12 for near and mesopic. She did all tasks except mesopic reading tasks. So then we say, okay, tell us which bit of your vision would you like to see more? And she said, improve my distance vision more. So because she wanted better distance vision, we then used the standard symphony rather than the trifocal to get her better contrast for distance, and again did LRIs because the LRIs worked here very well, and she did very well. So 4 weeks post-op, her binocular panfocal is 6-6, 6-6 for intermediate, 6-7-5, and 6-12, and she did all tasks except reading the telephone book in dim lights, and we didn't need any bioptics as such. The whole thing in these kind of situations is it's uncertainty. You don't know how it's going to pan out, and the way you would approach it will work, I would approach it will work. But it's something about communicating to patients what to expect and how we get them there. She did complain that she struggles to cut her toenails. So, shall we stop there?
No, we have 5 more minutes, sir.
Okay. So in order to, we've talked about the patient side of it. What about as surgeons, what we do? Well, we've talked this morning about refractive targeting and all the issues. You have to get the targeting right, the measurements right, you need the surgery correct, and if there are issues with spherical targeting, then you need to have strategies in place to correct that. So this is a lady who was a senior nurse. We did a Technis multifocal, and she ended up with significant residual refractive error, mainly on the astigmatism side for some reason. She noticed halos and rings during the day and night, and impossible to drive, can't work, computers, play. It's a nightmare situation, really. So the question is this lady not adapting to the halos, or is this lady having problems with the residual refractive error? How would you work it out? Shall?
We can, the easiest way I would think to find out is just give her a pair of glasses. And if she feels better with it, then that's the problem.
Exactly. Spot on. So you give her a spectacle trial, and that's what we did. She used the spectacle for 6 weeks. She said, if you get me that vision, I'm extremely happy. So then you know it's just a pure refractive error issue, and you can get that sorted out. And that's what happened. We did that. So I won't go through this, the whole assessment and enhancement and all that. But this is the other use of the panfocal methods that we use. So another patient, mix and match, Technis, resume, VA after surgery, 6-12 and 5, +1 and 6-5, and the other eye's perfect at that. Uncorrected, binocular panfocal, 6-5, N8, N5, N5. Best corrected, so distance corrected panfocal is 6-5, N12, N5, N5. Would you enhance the right eye? Why not?
Oh, yeah, I think given a spectacle trial and then see the evidence.
Okay. Any other takers?
I would do LASIK.
Okay. So if you correct that +1, her intermediate vision binocularly gets worse. So that binocular panfocal, the distance corrected panfocal, is worse for intermediate.
Oh.
So, but you would not have found this out if you hadn't done that panfocal measures. So it's like having a defocus curve, but only snapshots of it so that you can use it in a clinical manner. So this kind of assessment is very critical, I think, because you would go ahead and enhance it. The patient will say, oh, my distance vision is better in that eye, but my intermediate's worse. It's not good. So you can say to the patient, okay, if we do this, your intermediate will get worse. Are you happy with that? So when you enhance, what do you choose? Do you prefer the laser or putting a piggyback lens in?
Piggyback lenses, if the power is more than say 2.5, that is rarely happens. So
more than 2.2?
Yeah.
Okay.
That rarely happens. So unless in today's optical biometer. So prefer to do a LASIK after 1 month.
Okay.
Done ASA in one patient where I had no choice but I had to do it on 4th day. That was the earliest which I had done. The patient was relatively happy because she was from different country. Otherwise, after 1 month, regular LASIK, blade or no time for either.
No. Anyone else? For the last chef? For the last 6 years, I haven't enhanced a patient with lasers. Like piggybacks, purely because one, there's no ocular surface issue that you get with most of these patients. They are elderly patients, a lot of them. Secondly, for some reason in England, patients don't want laser treatment. They want lens replacement surgery. So they like the idea of a lens correction rather than a laser correction.
What's the reason?
That's the reason why they came. Refractive lens exchange, when they come for refractive lens exchange, they say, I don't want laser. They say, yeah, laser is going to be not good. Because they've read all kinds of stuff on the net and everything about all the LASIK complications, and Optimax ruined my life and Optical Express ruined their life and all kinds of stuff, and the FDA study. So there's a lot of negative things about LASIK which are more to do with patient selection rather than the actual procedure. But the fact is, that's how it is. So, and they also like the fact that you just come in, you do the case, and the next morning they're absolutely perfect. Because it's sudden, it's just quick, and it's a short 5-minute procedure to stick a lens in. So even for toric corrections, I use the Reina Sulcoflex. And if I need a higher correction, then I would start thinking of the ICLs for torics, but not otherwise.
If it's a multifocal, then more than the laser, I think the internal adding up a lens will be better, because if I have a multifocal inside and the patient needs an enhancement, you have something which is causing an internal abrasion as well, and then if I'm doing a laser, I'll be inducing some corneal abrasions as well.
Sure, but the amount of correction you're normally doing is so small that the increase in aberration doesn't make that big a difference. Right. So just to summarize, every lens on this planet works to its design. There's a good reason why Nikon and Canon and Zeiss and everyone have thousands of lenses for every camera, because they can't get one lens to do everything all the time. We only have a choice of putting one lens in each eye. We can't carry a wide zoom and a telezoom and this and that and everything. So we have to choose an average lens which works well most of the times, but is not perfect for anything. So that's the process of what's called optimization in optics. And so this particular zoom lens would have been designed to maximize its performance for long distance. But if you get that lens to work for near, it won't work that well. And that same process of choosing the aberrations as a compromise to optimize, that's really what it's all about. And all lenses are good because they work to their actual design. Retinal image quality versus focal range is the trade-off. Monofocal, spectacles, multifocals, bit of halo. Choose which compromise you want. Extended range of vision lenses, potentially a game changer because the contrast is higher possibly. And no IOL provides a perfect solution, and hence you need to customize the choice in each eye because you get 2 chances at doing that. So I think with current technology, we can get unaided binocular visual acuity of 6/9 or better for all distances in good light. To get better than that, we really need much better technology, much better understanding of things. Thank you.
Thank you, sir. Excellent discussion, excellent panel discussion. Also, we are really saying that we have come all the way from UK And we have enjoyed your talks, both the talks in the morning session and now, sir. We'd like to have more of you, but now, as we are short of time, we are closing this session. On behalf of the Poona Ophthalmological Society,